Yeah, so this is a very difficult question actually, and it's always very difficult to address those very common and difficult clinical scenarios when we have life-threatening infections in relapsed refractory patients. So this is especially important when we're considering patients who are post-allo transplantations, and especially those early relapses when patients are still unfit from transplant-related complications, and they do have a relapse, and then we need to consider low or high-intensity therapies to induce a remission again, and that is, of course, jeopardized by high risk of infections. I would say there are several factors influencing this. So first of all, it's the length of neutropenia, and that is a major risk factor for invasive fungal infections. So one of the possible reasons is, of course, offer antifungal prophylaxis for all relapsed refractory patients, irrespective of what salvage therapy they're receiving, whether it's intensive chemotherapy or targeted therapy or a combination of targeted therapies and intensive or hypomethylating agent backbones. I think the bacterial prophylaxis is also very important in these patients, especially during the pancytopenia and aplasia period, which can be prolonged, especially due to heavy pretreatment and the post-allogeneic stem cell transplantation setting. I think there are different strategies how different centers approach this, but one approach could be actually monitoring the epidemiological status, the colonization status of the patient, and offering the targeted prophylaxis antifungal, antibacterial therapies in this approach. Antivirals are also, I think, very important in this setting, especially for patients post-allo transplantations with severe immunosuppression. So we mustn't forget to monitor those patients for standard CMV, adenoviral, EBV infections and reactivations, especially if these are early relapse post-allo patients.